Okay, welcome everyone. We're very glad to have you here. We're glad you can join us on our webinar on preventing hospital-acquired infections with Dr. Tinsae Alemayehu. So before proceeding to the presentation, I'd like to say a few introductory words about Yetena Weg. So Yetena Weg is registered in Pennsylvania, USA as a non-profit, and it's run entirely by volunteer members. So it had a humble beginning consisting only of two founding members that has expanded over the years to include more than 150 active volunteer members across 5 different countries, counting more. So Yetena Weg's main engagements and projects can be divided into 4 aspects. So it's health and promotion, community engagement, mentoring and skill sharing, and medical education. So in health promotion, it usually participates by holding and engaging in discussions in article writings that are concerning the health of the general public, health policy and its implementation as well. So in community engagement, it's usually done by engaging in blood drive inclusivity trainings, blood donation campaigns, in fundraising campaigns as well. So it's mentorship and skill sharing program and engagement. Also is concerned with direct mentorship. So this is done usually either in person or virtually. So it could be either career and professional development, or it could be by teaching soft skills, and it could also be by could be held through webinars as well. So the last is medical education. So it has several aspects. The CME, the research and QI projects. So the CME is, as you've already seen, and as you're currently attending, it also has research and QI projects, which I'll come to later. So as you can see from this image below, that's projected on the screen, you can see several of our volunteers. As you can see on the right-hand corner, there are several of our volunteers that are volunteering in blood donation campaigns. As you can see in the middle, this is from one of our events, our Art and Health exhibition that was held a couple of months ago. And on the left-hand corner, as you can see, there are some of our members engaging in inclusivity trainings as well. So this is also another picture from our Art and Health exhibition. And on the right-hand corner is an image showing a donation that is being donated by Yetena Weg. So this is all to say that it's more than a digital platform. So Yetena Weg and ROHA also in collaboration usually prepare a health article writing competition, which is done in collaboration with IMSA. So the 3rd round of health article writing competition is going well underway in collaboration with IMSA. So ROHA Medical Campus, through its ROHA Health Foundation, will award travel grants to 2 health article writing competition winners. So the 2022 and 2023 overall winners have been announced. We'll show them the picture shortly. And Yetena Weg by itself will award pulse oximeters for the top 20 winners and litmus stethoscopes for the top 3 winners. The top 5 winners will also get internship opportunities at ROHA Health and other partner institutions. So this is an image showing the winner of the 2021 and 2022. The 2021 winner on the left-hand corner, and on the right-hand corner is the prize that was going to be awarded to the 2022 winner. The winner was announced virtually. So Yetena Weg, in collaboration with ROHA, has also engaged in ROHA Research Fellowship Program. So its main mission was to increase the versatility of healthcare professionals in terms of applying the scientific research to healthcare practice, to create a space where healthcare professionals can showcase their research endeavors and get inspired, and to foster recognition in the commercial and business world, and to encourage the key stakeholders and business entities to invest in the scientific research. So it was started on March 14th in collaboration with Addis Ababa University, the medical facility, or the Kurambasa hospital. So 3 departments were mainly participating in this research fellowship: oncology, radiology, and internal medicine. And research grants were awarded for 4 winners, mentorship for the next 10 nominees as well. So it was also done in collaboration with St. Paul Hospital Millennium Medical College. The main targets here were the medical students, mainly interns, as part of the partial fulfillment for degree in Doctor of Medicine. They usually had to submit independent or individual research. So they were given the opportunity to present their research to this research fellowship award as well. So it is well underway. It has been already launched, and we've been notified that more than 80% of the evaluation process has been completed, and the winners will be announced shortly. This is the image showing the winners from Tukur Ambassa Hospital. There were 2 residents from internal medicine, 1 resident from radiology, and another resident from oncology. So besides the monetary compensation, they will also be able to participate in several mentorship as well as in guidance, which will further help in their future ventures. So coming to the CME, as you all know, CME stands for continued medical education. So our CME is freely accessible, and Yetenaweg partners with Ethiopian Medical Association, Ethiopian Society of Cardiac Professionals, Ethiopian Dermatology and Venerology Society, and Ethiopian Society of Internal Medicine to provide continued training to healthcare professionals. We've had 30 CME webinars so far. Our average webinar attendees vary from 150 to 200 healthcare professionals. So in 2023 alone, 40 webinars focusing on non-communicabilities, on current issues, on mental health and then sexual and reproductive health rights have been held. So on our CME, we invite renowned international speakers that are experts in their respective fields. So you can access our previous CME sessions on Yetenaweg's official YouTube link. The link is already posted in the chat. You can access it later. So in order to get updates about our upcoming CMEs, you can join Yetenaweg's Telegram channel for healthcare professionals. Link has been posted as well. Or you can follow our social media posts. It could be Twitter, Facebook, LinkedIn, Instagram, whichever you find convenient, where updates will be posted regarding our upcoming webinars. So we also have various topics planned for 2024, each more interesting than the previous. So if you can join our social media, you'll directly get notifications regarding the upcoming webinars. So for best experience in the webinar, you should send your questions to the Q&A or to the chat box directly, whichever you find convenient. At the end of the webinar, you'll have a chance to ask the speaker directly if you raise your hand. And in order to get CU certificate, the attendees must be able to fulfill the following set criteria. The first is you should be able to attend the whole sessions virtually. So the minutes attended will be checked by the Zoom attendee report. You should be able to fill the Google form for personal details and attendance, along with the post-CME quiz at the end of the webinar. You should be able to get 50% and above on the post-webinar quiz. So you will get your results right away, but the certificate will usually take 1 to 2 weeks to be delivered to your email. So we ask that you wait patiently. So this is, I've said a few things about Yetenaweg. So today's webinar on preventing hospital-acquired infection is prepared in collaboration with the Ethiopian Society of Internal Medicine and ROHA Medical Campus. So we'd like to extend our thanks to both of these respective parties. So we have a special guest today. Our guest today is Dr. Tinsae Alemayehu. He's a pediatric infectious disease specialist and an associate professor. He's passionate about clinical infectious disease practice and medical education. He's well published in his research interests focus on antimicrobial resistance and stewardship. Not only that, he's also one of the founding members of Yetenaweg. So having said that, I would like to welcome Dr. Tinsae. So Dr. Tinsae, the floor is yours. You can proceed.
Okay. Good afternoon, everyone. It's always a pleasure to be involved in CME activities with Yetenaweg. It's now coming up to almost 4 years since this initiative was started. And I'm very proud to have been one of the first contributors, and also proud to see the level to which it has grown. So today we'll be raising a very important topic, which is preventing infections in hospitals. So throughout the discussion, I'll try to briefly take you through what infection control programs in hospitals should look like and what they should consist of. So infection control is a gradual process. Controlling antimicrobial resistance is a gradual process. It requires patience. Its results are not immediately apparent. So it requires team building, ensuring that the correct systems are in place at each level of the hospital, starting from the administration all the way down to the first line professional. So throughout the discussion, I'll be referring to my own personal journey, personal experience over the past 8-9 years, trying to implement such infection prevention and control policies in the different institutions that I have been affiliated with. So this is the framework of discussion that we are going to follow. So as you can see on the uppermost tier of the slide, you see there are two main essential things that have to be put in place as a base to design infection prevention and control programs. These are the availability of proper diagnostics, your ability to identify or recognize what is going on around you, and the second is education. What are you going to do with what you have recognized? So these are the two things that really the initial investments should be pumped into, so that out of these two you get properly designed IPC programs. And then the IPC programs themselves, they have, of course, various different arms, but I've tried to group them into surveillance, outbreak investigation, pre and post exposure prophylaxis or occupational health principles, as well as guideline formulation. So I'll use this template to proceed with my discussion. So step one is diagnosis. So what you don't identify, you cannot treat, and what you don't identify, you cannot prevent. So our aim here is to prevent hospital-acquired infections. So as you know, there are rising rates of antimicrobial resistance in Ethiopian hospitals. It's not uncommon to hear among doctors, among colleagues, for your colleague to say, I don't know what's going on, but there is an unknown outbreak in my ward, which is claiming a lot of lives. Our ICU admissions are passing, and we don't know what's going on. We don't know the source of that infection. Immediately post-op, our success rates are not optimal. So often the extent of the problem is under-recognized because we do not have the recognition tools. So better tests, basically, better tests lead to better care. And that, just to share with you our experience at Black Lion Hospital. So in 2015, we tried to implement a long-term infection prevention program and tried to identify, because there was huge amounts of antimicrobial resistance, we tried to identify where the source of that antimicrobial resistant bugs were. So we enrolled about 1,000 patients, did more than 770 blood culture testing in patients of all ages, and we identified a 30% bloodstream infection rate, with 80% of Enterobacteriaceae, gram-negative bacilli, being cephalosporin resistant, and 23% being carbapenem resistant. This was 2015. I'm pretty sure now, almost 8 years on, if similar studies are conducted, we may have even higher rates of carbapenem resistance. And due to this very highly drug-resistant organisms, which were being easily transmitted from ward to ward, from a laboring mother to her newborn during operative procedures, a mortality at 14 days of admitted patients with bloodstream infection was shown to be 31%. So this was a wake-up call for hospital infection prevention efforts, because suddenly we were aware where we stood. So that's why I say always diagnostic capability is number one. The next thing is education. Okay, so you have your appropriate tests, you have fancy tests, the latest technology, but the tests won't order themselves. Okay, this requires a knowledgeable professional to identify what test to order and for what clinical scenario. So education is key, especially with regards to antimicrobial stewardship. So what do you use, when do you use to identify an infection or an outbreak, and then finally to set out plans to prevent its spread. So a major cornerstone of this IPC or infection prevention control education is how to use your antibiotics properly. So the first thing is, are you really dealing with a diagnosis that requires an antibiotics? And so have you made the necessary pre-antibiotic workup to avoid the scenario like I just mentioned, that to avoid a multi-drug resistant or extremely drug resistant bugs spreading through the hospital? So there are different arms to improving such education programs. So there should be a strong focus on infectious diseases and clinical microbiology training, as well as actual clinical practice for existing hospitals as well as for newly opening hospitals. Usually, newly opening hospitals and medical schools give emphasis to uh, the medical disciplines with immediate fruits or immediate returns, such as procedural medical disciplines, or it could be ICU care, etc. But throughout all this process, they skip on the infectious disease and clinical microbiology sections of the hospital, which hold everything together, okay, so that every other medical discipline functions well. I would even go to suggesting to make it mandatory for issuing and renewal of licenses of health institutions. So having such IPC programs, ID programs, and clinical microbiology programs should be essential for a hospital to even start practicing or to continue practicing, because it is one of the main reasons for a hospital's success. So then, of course, you have the CMEs for professional societies as well. So the impact of education. So just moving on from the research that I shared with you early on, starting December 2015, our research team at Black Lion Hospital, once we identified where we stood, implemented the following interventions, educational interventions. We wrote standard operating protocols for the microbiology labs. We trained laboratory staff um, uh, with serial trainings, with the aim uh, to have a better performance from the microbiology lab, and also for encouraging better communication of the microbiology yields with treating teams, so that the treating teams are confident with what they are getting from the microbiology labs, and the microbiology labs are getting the uh, um, uh, correctly collected samples from the clinical teams. Because if the clinical teams are sending bogus clinical samples, then the microbiology teams will have bogus results. And then that is a vicious cycle, because then those results will be communicated to the treating teams, and the treating teams will frustrate because the resulting microbiologic result does not correspond to what their patients are clinically experiencing. So in order to boost confidence of treating teams who have forgotten how to do a pre-antibiotic workup, we implemented education strategies. So pre-intervention, the average number of specimens which were handled by the microbiology labs due to this distrust among professionals was 15 a day. So just to give you a background, Black Lion Hospital handles more than 30,000 admissions per year. So with that background, 15 specimens of microbiologic samples per day is very, very, it's minute, it's even less than minute if there is a word. And the number of blood cultures which were being processed were only 2 per day. Then after serial educational programs, trainings, both for both clinicians as well as microbiologists, post-intervention, we started to see a spike in order, okay? The microbiologic yield improved. It started to pick the causes of the hospital outbreaks that were going on. Then when they saw that, treating teams began to order more, and what used to be 15 a day jumped 5 times to 75 a day, and the number of blood cultures in a few months has jumped to 45 per day. So this is the impact of education, which leads to better detection. You have the diagnostic tools, and then you've been armed with how to use them. So a very powerful tool here, an education tool, is antimicrobial stewardship. So antimicrobial stewardship is a very important wing of infection prevention because it asks the following very important questions. As I've said, do you have an infectious diagnosis worthy of antibiotics? Have you done the necessary workup to reach the infectious diagnosis? Are you giving the right antibiotic, assuming that there is a bacterial infection? And assuming that you are giving the right antibiotic, are you giving the right dose? And if you have made a correct diagnosis and if the answers to the above 4 questions are correct, then how long do you plan to treat? And what are your cues to stop? When do you stop? Okay. So we established an antimicrobial stewardship practice, the first antimicrobial stewardship practice comprising of physicians, infectious disease doctors, clinical pharmacists, and microbiologists. And we made rounds twice a week in pediatrics and twice a week in internal medicine. And we collected data on more than 1,000 patients and studied what happened before we implemented stewardship procedures and after we implemented the stewardship procedures. So basically what we did was it's a round, but we sat with treating teams and then we went through the admissions and asked the questions that I just posed earlier. Do you have an infectious diagnosis? Okay, and are you giving the right antibiotic? Are you over bombarding them with potent antibiotics or just the right antibiotic? Are you giving the right dose? And are you giving them for more days than is justified? Okay, and we gave recommendations according to that, and the treating teams countered with their own questions, and we reached to a consensus, and we moved on to the next patient. That was how things happened. So pre-intervention in the hospital, millions of birr were being spent on purchasing especially 4 antibiotics, meropenem, ceftriaxone, cefepime, and vancomycin. And during our stewardship rounds, we noticed that 54% of the charts we reviewed, led to discontinuation of antibiotic therapy because patients were being overtreated more than necessary. There was no infectious diagnosis. It was actually a non-communicable diagnosis. The investigations of the patient did not support an infectious diagnosis, or in severe cases, all of these three. Okay, so because we were sitting down with the treating teams and holding small meetings so that we have a report, 96% of our recommendations were accepted, and within a few months, utilization of broad spectrum antibiotics dropped significantly. So this, of course, has the main target, improve the patient outcomes, because they don't stay for longer than necessary in the hospital. That means they are not exposed to more nosocomial pathogens than necessary. Okay, that means less hospital acquired infections. They don't incur unnecessary costs. That is also significant for the hospital because, as I will demonstrate later, the hospital also saved a significant amount of budget because antibiotics were being prescribed more than necessary. So for every 1,000 patient that more antibiotics were corrected, the hospital was saving about $82,000. So that is the impact of antimicrobial stewardship. So it is a very important cornerstone of infection prevention and control. So far I've been laying the groundwork: better diagnostics, better education and personnel. Now you have a properly formulated IPC program. Then the next thing is the first subgroup of an IPC program is surveillance. Okay, where are these nosocomial pathogens located? Where is this? Where are these outbreaks occurring? So the number one place that we should look at is our hands. Hand hygiene is the most important intervention tool for maintaining infection prevention and control in a hospital. So sanitation, food and water contamination control, washrooms, and unclean washrooms also propagate multi-drug resistant bugs. So that is a very important area to look. The other is medication contamination, IV fluid contamination, blood products as well, devices in the hospital, the doors that you touch, the trolleys that you push, the IV needles, okay, the procedures that you conduct, your phones that you carry, your rings, your jewelry, okay, all of this closely attached objects are very important sources of infection occurrence. Then overcrowded rooms, infestations such as rats, cockroaches within medical wards, and are another area that we should look at, and also improper antibiotic use leading to spread of antimicrobial resistant bugs is also another. So this is where the first group of activities of an IPC program should focus: the surveillance activities. So hand hygiene compliance is actually, I expected it actually to be much more poor than the papers that I have read on this. Pooled hand hygiene compliance among healthcare workers in Ethiopia is was shown to be in 38% of participants, according to a systemic review. And MRSA nasal carriage stood at almost 5% of healthcare workers using the MRSA genetic mutation testing. So basic determinants of hand hygiene are, of course, knowledge, how to keep proper hand hygiene, The supply of water and soap. This is one of the major challenges in a hospital. So you talk about hand hygiene all day, but if the hospital does not have an adequate water supply, an adequate soap supply, alcohol rub supply, etc., then this falls on deaf ears. And also functional sinks also. How many of our hospitals have functional sinks? How many are broken? How many are maintained? These are very basic things that should be kept in mind when you design proper hand hygiene programs. So the other is infestations, okay, infestations. So this is a landmark study which was done in 2012 by a colleague of ours, a pediatrician, Dr. Birkana, and his colleagues. So this study showed the presence of a high load of multi-drug resistant nosocomial neonatal pathogens, which were carried around by cockroaches in the neonatal intensive care units at Black Lion Hospital. So all the time you are looking at your hands, you are looking at the who comes in, who goes out, who is wearing what, scrubs, headwear, everything. But these little bugs are under your feet, scurrying around the rooms, carrying multi-drug resistant pathogens. So this was a very important study which notified the hospital what was going on at the time. So the other important study that I also would like to share again from the same hospital is this one, which was published by Dr. Tolosa and his colleagues on bacterial isolates from cell phones and hands of healthcare workers. So this was in the pre-COVID era, and 85% of study participants never cleaned their cell phones in pediatric wards at Black Lion Hospital. 78% of healthcare workers used their cell phones while working, and the bacterial isolation rates were very high. So Staph aureus, coagulase negative staph were being isolated in up to 78% of hand swabs and 3 in 5 swabs from cell phones. Okay, so while you are working, unless and absolutely essential, so you are examining a patient, and then 1 or 2 patients later you are answering a call, and then another call. Okay, these things are unaddressed causes of spread of infection. It's human nature that when you are observed, you perform well, and when you are not observed, you forget to perform well. So observation of hand hygiene practice when IPC nurses, infection prevention and control nurses, were monitoring closely, and when the hospital workers thought that nobody was monitoring them, were very much, they have been studied and they're very much different. Okay, so there are multiple ways that hospitals implement such hand hygiene monitoring. So they can actually come whereby everybody knows that there is a hand hygiene round or a hand hygiene feedback session. So they will come, those nurses, they will see who's implementing hand hygiene, and they give evaluation and feedback. And then some centers even use progressive assessments of their healthcare workers as with regards to hand hygiene as part of their annual performance evaluation of workers. And some others do hidden rounds, okay, without wearing any scrubs. Just there will be assigned individuals roaming around the wards unbeknownst to healthcare workers, and they do their assessments as well. Any one of these that you implement will educate health personnel and contribute to better hand hygiene. The other, of course, is microbe surveillance. Some multi-drug resistant organisms can be screened for before patients are admitted. So one of the biggest things that we encounter in newborn intensive care units, for example, is the high prevalence of multi-drug resistant Klebsiella infections. In some other institutions, they have a higher prevalence of methicillin resistant staph, vancomycin resistant enterococci, etc. So if you have identified a higher than normal occurrence of a particular organism, okay, in your patients, then, and if that resistance pattern also exists within the community, so you can do screening upon admission of all patients for MRSA, multi-drug resistant gram-negatives, vancomycin resistant enterococci, and then you can segregate patients according to their results, so that the occurrence of one of these bugs in one patient does not cause a ward outbreak. So outbreaks overall can be transmitted by three main routes. You can have aerosol, airborne route, droplet route, and contact route, or sometimes organisms use all three routes. I'll be discussing this a little bit later on. So when, as I've said, when we are observed, we do better. So for this Taiwanese study, which was conducted in a tertiary teaching hospital over a year period, they monitored more than 30,000 hand hygiene opportunities. So they did 4,500 out in the open with everybody seeing, and 26,000 hidden from the eye. So overall, hand hygiene compliance was very high when someone thought that they were being observed, 78%, versus when they thought that nobody was controlling them, or 55%. So this was what I was speaking about earlier. So the other thing is, so far I've been discussing about surveillance. Okay, so having an idea at any given point about what's going on in your institution. Then you have outbreak investigations. Okay, so you have implemented all of those, but it happens. That's the fact of the medical care. Outbreaks can occur. So when do you say an outbreak has occurred? When you have a higher than normal number of a known diagnosis, or even a single new diagnosis, then you should be concerned about the beginnings of an outbreak. So the reason why you conduct investigations is, of course, to prevent additional cases from occurring, to understand if it's a new disease, why it occurred, what is transmitting it, what is the source, to prevent future outbreaks, to minimize economical and social disruption, and of course, there is also a legal obligation, because such type of outbreak cannot occur under your watch, and many patients cannot suffer from it. So the steps in investigating outbreaks include verify who, okay, the etiology, where, the source, how, the vehicles, the transmission methods. Then you write a case definition. What is a confirmed case, a probable case, a possible case? So you try to understand the severity of the situation, how many are infected, how many are dying from it, how many are being hospitalized from it. And then you develop what's called a line listing of cases. So this is just age, gender, risk factor, comorbidities, diagnosis, drugs administered, where the patient was admitted in, so that with each new patient suffering from an outbreak, you write down in your list, somewhere down the line, a pattern starts to appear as to patients will have similar risk factors or similar ages, or were admitted to a similar ward. So in order to pick patterns, you develop a line listing. Then you analyze past cases to learn from history, what has happened in your hospital 10 years ago, 5 years ago. And then you implement control measures And then, of course, you communicate and document findings, because all of what's going on needs to be communicated to public health institutions within your city as well as within your country. So once you confirm the outbreak, then there are various ways that you can control those outbreaks. So earlier on, I started discussing about this. Contact, droplet, and aerosol, and sometimes all three can be utilized by microorganisms to be transmitted from one person to another. So contact precautions are, you need only gloves, for example, because only touching shared objects or touching infected individuals can transmit infections, and without the appropriate precautions. So, but all other, for example, respiratory precautions are not required. Then contact plus droplet precautions. There are some organisms which are transmitted by contact as well as droplet. This includes respiratory droplets, which can only be transmitted if you are closer to 1 meter or less to the patient. Okay, because these are large droplets, large particles, more than 5 microns. They cannot be propagated long distances. Okay, so if a person is talking, coughing, sneezing, and if you are close enough, you can acquire it. But you cannot acquire it if you are standing more than a meter away, or just at the entrance of the ward or whatever. The third mechanism, the aerosol transmission, does exactly that. Whether that person is closely present to the patient or far, then since the particles are minute, they will be transmitted far distances and can infect patients. So if, for example, you are wearing a surgical mask for a droplet precaution, you may use N95 for aerosol precaution. So the level of care that you implement will subsequently increase. If you have microorganisms which implement contact, droplet, and aerosol, they are transmitted in all three methods, then your level of infection prevention measures should be very strict indeed. And one of the techniques that some hospitals implement is, as you go from ward to ward, before you enter a patient's room. This especially works if there are rooms which only house one patient. Okay, so you just look up at the entrance of the room, and there are color codes that are used to communicate the level of infection prevention measure that the healthcare worker should use when entering that room. So if you see green, for example, it's just hand precautions, contact precautions. If you see yellow, then of course you have to wear gloves and then maybe a surgical mask, because the diagnosis that that patient has is caused by an organism that uses contact as well as droplet. If you see red, then you will be fully suited with proper N95 gloves, gowns, so disposable gowns, etc., because the organism that's causing that particular disease in that patient uses multiple ways to be transmitted. So, here are some examples of diseases that can be transmitted by aerosol, such as measles, TB, chickenpox, COVID, and then droplets or larger particles such as pertussis, adenovirus, etc., and then contact, hepatitis A, herpes simplex, impetigo, Staph aureus, strep, scabies. Such infections utilize the contact route. So Once the outbreak has been identified, once you know how it's being propagated, then provision of prevention equipment such as gloves, long-sleeved gowns, medical masks, N95 masks, facial goggles. These are very important, and also isolation rooms, properly staffed and properly equipped isolation rooms are also necessary. One of the infection prevention tools that we utilize in isolation rooms is negative air pressure and dedicated exhaust systems so that airborne contaminants do not travel outside the room. So this isolation room should have a minimum of 12 air exchanges per hour using medical high efficiency particulate air or HEPA filters. So these are designed to remove almost all of airborne particles that are more than 0.3 micrometers in diameter and are very important in outbreaks which utilize aerosol mode of transmission. Isolation rooms can also implement UV radiation, UV germicidal irradiation. So this provide disinfection zones whereby viral particles die and stop being propagated from patient to patient. So UV disinfection is not only useful for isolation rooms. It's also important for areas, especially in the context of Ethiopian hospitals. There are high-risk areas whereby there are overcrowded sections such as hospital waiting rooms, reception areas, hospital cafeterias, duty rooms, areas where it's difficult to stay at least 2 meters apart from others. So all of this essentially can act as a pseudo isolation room because it's not only the conventional isolation rooms, but these are also high risk areas. Then the third cornerstone is occupational health. So our main focus so far has been on patient care, but then the healthcare worker care is also very important because if healthcare workers are not healthy, then the risk of transmitting to their patients is also high. So healthcare is associated with many occupational risks. So you need to have a pre and post exposure care unit, dedicated unit, whereby if a healthcare worker is exposed, they immediately know where to go, how to get the service. So when you look at occupational exposures in healthcare workers, 39% of hepatitis C infections which occur in healthcare workers occur in a hospital setup. 37% of Hep B infections, new Hep B infections in healthcare workers occur in a hospital setup, and 4% of HIV infections. So you can see to what degree of exposure healthcare workers are exposed to when conducting their daily activities. So some organisms require more attention, especially hepatitis B, whereby the risk of transmission can go up to 30% per incident. Hepatitis C also 10 times less than hepatitis B, but still a significant cause of bloodborne transmission of infections. And of course, HIV also. So each one has its own, should have its own policy within the hospital. Where should a Hep B, Hep C, HIV exposed person go to? Who should they talk to test? Who should they talk to get prophylaxis? This should be clear in every wards. There are also immune and chemoprophylaxis scenarios. So immune is you just give vaccines. Chemo is you give medications to prevent transmission of infection. So things like meningococcal infection, if there is any health worker which has been in direct exposure to an index's respiratory secretions, unprotected mouth-to-mouth resuscitation, intubation, etc., then they require antibiotic prophylaxis, ciprofloxacin, ceftriaxone, etc. Or in the case of outbreaks, they should take vaccines. Varicella infections, there are multiple ways that you can prevent infection: immunoglobulin, vaccines, and also antivirals. Varicella infections especially are very harmful for immune compromised healthcare workers and pregnant non-immune healthcare workers. Okay, so in these individuals, in immune compromised healthcare workers, the risk of disseminated varicella is high. In pregnant non-immune workers, fetal varicella infections can result and lead to musculoskeletal, neurologic deformities, etc. So these policies should be present. If there is a child with pertussis in the wards, then prophylaxis with macrolides should be given to healthcare workers which are taking care of infants, because in order not to act as a medium of transmission. If there is an expecting mother, healthcare worker, within 1 month of delivery, she should also start chemoprophylaxis. Um, so these are high risk scenarios. Of course, hepatitis B is another very important source of occupational um, health hazard. So vaccines and hepatitis B immunoglobulins should be administered if a healthcare worker is non-immune and within the first 24 hours, but really as soon as possible after exposure. And of course, chemoprophylaxis for HIV also at the earliest opportunity should be given, because if administered properly and early, it can lead to more than 80% of risk reduction when it is adhered to. So we have discussed surveillance, we have discussed outbreak investigation, we have discussed occupational health. The final wing is instituting guidelines and antibiograms. So if everyone sticks to professional antimicrobial guidelines, then the risk of abuse of antibiotics will be minimized, and the risk of antimicrobial resistant organisms disseminating also will be minimized. So antibiograms are real-time antimicrobial resistant data for that specific hospital. Okay, for that specific. So every textbook that you read, when they report, or when every research that you read, when they report a resistance rate, it only applies to them, to that country, to that hospital. Even within the same country, even within the same city, within the same sub-city, hospitals may have different antimicrobial resistance patterns. So antibiograms are a summary of your antimicrobial resistance rates for the past. It could be 1 month, 2 months, 3 months, and they are abbreviated in a form of pocket guide or mobile apps. And you can see, for example, if your patient has E. coli, urinary tract infection, you can see in the past 3 months among your hospital-acquired urinary tract infections, how many of your E. coli were sensitive for a certain antibiotic, were intermediate, or were resistant. So in our experience, in 2018, we implemented a mobile application, first at Black Lion Hospital and later at St. Paul's Hospital, and shared antibiograms specific to Black Lion Hospital. The picture on your right is a bit blurry, but you can see a lot of red, which corresponds to a lot of antimicrobial resistance. So red signifies 50% or more likelihood of resistance. Yellow is 50 to 75. Green is more than 75% susceptibility. Okay, so sorry, let me rephrase that. Red is 50% or less susceptibility rate. Yellow 50 to 75 susceptibility rate, and green more than 75% likelihood of susceptibility. So you see very few green, a little bit more yellow, but almost large sections of red. That was what we were dealing with at the time with multi-drug resistant organisms. So if you will have this in as a sort of a pocket tool, a pocket guide, you just take it out and then refer to it and then consult it to design your patient's antimicrobial treatment. So how it's interpreted, this is another antibiogram, which is from a hospital in the UK. You see the numbers. These numbers correspond to the percent susceptibility. And then, of course, guidelines are very important. So we have long experience with very good local guidelines, such as the St. Paul's Hospital's Pediatric Antimicrobial Treatment Guidelines, the Black Lion Hospital Antimicrobial Treatment Guidelines. There are very good international guidelines that you can refer to. Africa CDC Antimicrobial Treatment Guidelines, Infectious Disease Society of America, European Society of Clinical Microbiology, and Infectious Disease Guidelines. So adhering to antibiograms and guidelines is also a very important thing. I will conclude with one very important aspect. Whatever healthcare workers do, whatever successful infection prevention and control program is designed, if there is no buy-in from admin, from the hospital administration, then everything crumbles. So the hospital administration of a newly set up hospital or an existing hospital should believe in the short-term and long-term benefits of infection prevention efforts. So the administration should support with providing reporting systems for public health authorities. The IPC team should be well publicized. Notices should be set up everywhere. Exposure clinics should be known to every health professional, and procurement of infection prevention and control equipment and medications are very important for optimal patient outcome, as well as optimizing hospital expenditure. Systems should be in place how to best use staff according to their comorbidity. And pre-employment screening is also important for healthcare workers as well. So how best to utilize staff means, for example, if a staff is, a healthcare worker is exposed to hepatitis C and they are properly treated, they can perform regular tasks, because the aim of treatment of hepatitis C is cure, not suppression. So if treated and cured, then that healthcare worker can be involved in any healthcare activity. If HIV viral loads are suppressed, or if a worker is with chronic hepatitis B has a low likelihood of transmission of hepatitis B with negative HBe antigen, low viral loads, then they can be assigned to patient care, which does not involve invasive procedures, and of course in compliance with existing infection prevention practices. So this knowledge among hospital administration is also very important. And another condition that should be always kept in mind is pregnant individuals. They have poor, so there are two arms of immunity. So you have cellular and humoral immunity. Humoral immunity is unaffected in pregnancy. So infections which require adequate humoral immunity, you don't need to institute any further precautions. But pregnancy is associated with poor cellular immunity. That means immunity towards viral infections, fungal infections. This is impaired. So non-immune pregnant healthcare workers should not care for patients with infections like measles, rubella, and varicella, which have implications on the health of their fetus, and should not receive live vaccines as well. So this is where a good administration comes into play. So in conclusion, proper diagnostics, proper education, then you have your IPC programs, and then those IPC programs will through them run proper surveillance, outbreak investigation, maintain occupational health, and make available the necessary guidelines and antibiograms for their hospitals. This altogether will lead to a good control of infection prevention in hospitals. Thank you very much for your attention. I will leave the space open for questions.
Thank you very much, Dr. Tinsae. It was a very interesting session. I think you've provided a comprehensive coverage of the strategies and the best practice for preventing hospital-acquired infections. So thank you very much. So as I have said earlier, this webinar is made in collaboration with Ethiopian Society of Internal Medicine and ROHA Medical Campus. And from ROHA Medical Campus, Dr. Ethioel has joined us today. So Dr. Ethioel will have closing remarks. So Dr. Ethioel, the floor is yours. Please proceed.
Okay, thank you. Good afternoon once again. Thank you, Dr. Tinsae, for your very important and summarized and concise discussion. It was very impressive and marvelous. So to say, to introduce myself, to begin with, my name is Dr. Ethioel. I'm an internist. I work with ROHA Medical Campus as a hospital operations specialist, and we are glad as ROHA Medical Campus. We are glad to be engaging with such a beautiful discussion. So for some of you who does not know about ROHA Medical Campus, ROHA Medical Campus is a hospital under construction near Bole, and it's going to be a big facility with 350-bed hospital with all the specialties you can imagine. And the overall aim of the hospital is to provide quality service and to provide the desired and the needed clinical service for Ethiopians, and also to decrease the outbound medical tourism and eventually to increase the inbound medical tourism. That is the overall aim of this facility. And as an internist, me myself, hospital-acquired infections are, one of our daily routine challenge, and as Dr. Tinsae clearly mentioned it, the challenge starts from diagnosis, and then it goes to treatment, and it continues to follow up, and it continues throughout the patient care, because it's not just a diagnosis problem. It's not just a treatment problem. It's a systematic problem. So we need a better system to handle this huge burden on the healthcare system. This is not a burden not only for Ethiopia, but also throughout the globe. It's a major problem. So to say a few points, what we're trying to do regarding this minimizing hospital-acquired infections is, the first and the most important thing is we know the burden. We understand the burden. So I myself have suffered a lot of challenges, if not daily, during our clinical activity. So we understand the challenge. So how can we address this challenge is the question. So as clearly discussed by Dr. Tinsae, the challenge is multiple. So to begin with, think of our facilities, for example, the hospitals, the big hospitals we have, be it public or private. Imagine one of the tertiary hospitals and think of the space they provide for, for the emergency department, for patient waiting area, the imaging unit, the ICUs. Imagine those places and imagine the space allocated. So mostly the tendency here in our country is to utilize the space in a money generating way as much as possible, but that will have a negative implication on the patient outcome. So what we did is, so we will have adequate space throughout the service areas and the waiting areas. And to mention those few areas, for example, the initial entrance lobby is double volume. It's so big, it's so wide, you are not going to feel really, congested in that wide waiting areas, the corridors, the entrance area, the lobby, and so on. So that's very important. Space is very important. COVID has taught us a great lesson. So facilities, they have to allow adequate spacing so that to minimize infection spread. That's one of the most important area. The other is, once we have said the space, the other is, the diagnosis. So for you to treat and tackle a problem, then you have to know the problem exists. So the diagnosis is the challenge. As rightly said by Dr. Tinsae, we know how much the yield is from most of our microbiology departments. The yield is not as we want it. We can leave it there. So we are working and we will take a major undertaking regarding the diagnostics that can be, in terms of microbiology and advancement in technologies. There are a lot of technologies that helps you diagnose infectious pathogens by using, PCR and so on and so on. So the lab will be equipped, at least what we can say is the laboratory will be equipped with important and cutting edge technologies for health professionals to be able to diagnose what's going on. And the other is, appropriate treatment. So appropriate treatment is, once when you say appropriate treatment, it bases once the knowledge, the clinical knowledge. The other is the availability of the treatment modalities. So we'll make sure our team is well trained and well equipped with the with the knowledge that's required. We'll make sure that happens. And also the other important thing is, making sure those treatment access are available. For example, we know that, for example, a patient with neutropenic fever, let's say, the fungal infection prophylaxis is going to be, he is going or she is going to be on fluconazole. And also the treatment is going to be fluconazole because we don't have much option regarding antifungals. So now most of the facilities, physicians know what they want to do, but there is a significant setback from availability point of view. So we'll make sure those treatment items will be availed. And the other is, we understand the significant importance of, antibiotic stewardship programs. So it will be incorporated in the system. And also Dr. Tinsae made a remark that I couldn't agree more. Most of our facilities focus on, immediate return of investment. This ROHA Medical Campus is not an investment we have seen in this country. It's not like any other investment because it tells you the way we are engaging with, every stakeholder. It tells you the project is different. So the fact that we are planning the clinical activity from this point on, it tells you how dedicated and serious we are to improve the quality of service. And the other important point Dr. Tinsae also mentioned is, for example, think of our ICUs. How many patients will be in one room? Maybe 6, 10, you name it, 14. So this imagine the ventilator patient. Some of the patients, they have, resistant organisms. Some of the patients will have tuberculosis, and we don't have pressurized rooms. So that will be a problem not only for the other patients, but also for the healthcare professionals. So one thing we'll make sure is the ICUs, the wards, they will not be congested. The ICUs will be single bedded ICUs, and also the wards will be as such. And also the other is we'll implement, pressurized rooms in isolation areas. So the HEPA filter will be availed in these isolation areas. The fact that the rooms are single bedded will make isolation area much easier, but also in the design, we have included dedicated isolation areas in the ICU, in the ward, both adult and pediatric, so that the pressure is also planned ahead of time. So we have negative pressure rooms for the isolation areas. HEPA filters will be available. And also throughout the system, the heating, ventilation, and air conditioning system, HVAC, the system we call HVAC system, will be an efficient way of, ventilation and air filtration. It will minimize, concentration of airborne pathogens, so that hospital-acquired infection is generally as minimum as possible. And the other is natural light is, many studies have shown natural light is key in preventing, infection transmission. So the whole compound is, the whole building is designed in a way that allows adequate sunlight. And also, once again, COVID has taught us significant lesson in being flexible to withstand the dynamics of the healthcare challenge. So most of our facilities were not prepared for a challenge like COVID, especially something like airborne. We were not prepared overall as a nation or as a continent, we can say. So the design is designed in a way that's flexible enough to accommodate, healthcare challenges in the future. That's one critical area we have thought about. The other is, if you see the design of the hospital, the hand wash areas, the number, you'll be amazed. We have hand washing areas everywhere in the procedure places, and also treatment areas, waiting areas. So we understand the significance of hand washing, and hand wash basin is availed. And also the other critical point is the water source we have. Even if there is cut back on the water supply, we have a reservoir that can keep us going for many days. So we have prepared in that regard as well. And also the other most important area is, the healthcare professionals should be well trained so that we can deliver the promised quality service. So when we say training, it means rigorous training until the desired culture of that facility is met. So for us to deliver such a high level of service, we have planned a dry run. So we have planned a dry run. That means after commissioning of the overall facility, we'll have a dry run. We'll have a drill. It means simulation for months. So all our staff, including not only the healthcare professionals, but also the janitors, everybody who has a role to play in the service delivery, will be trained adequately so that we can deliver, the desired quality service. And overall, what I can say is, we're planning a service that is going to change the way healthcare is, seen in this country. We plan to be, the start of the domino, so that other facilities will follow our footstep and improve the overall health care service provision. So the team, overall, ROHA Medical Campus team is excited to be in such a project that can change the healthcare dynamics in our country and at large Africa. So we would be happy for everyone to be as excited as we are, and hope it will be sooner than later. So I'm very grateful for the honor from Yetena team for organizing such a important and crucial CME. All I can say is keep the good work up, and thank you, Dr. Tinsae, for your beautiful presentation. Have a great day. Thank you.
Thank you very much, Dr. Rigel. You've provided us with a very insightful information, especially regarding ROHA Medical Campus. So thank you very much. So dear participants, post CME Quiz link has been shared. We urge you to attempt the quizzes. There are approximately 4 questions. So having said that, we can directly proceed to the Q&A session. So the Q&A session will be hosted by my colleague and co-host, Dr. Mahalit. So Dr. Mahalit, the floor is yours. You can proceed.
Thank you. And we would like to thank Dr. Tinsae again. And I'll be sharing the questions. So the first question is, how does hand hygiene round proceed? And which infections need N95 mask for prevention?
Okay, so your hand hygiene round is not like your regular ward round. Infection prevention and control nurses, according to a schedule which is agreed upon, they do rounds. It could be 2 or 3 individuals, and they do rounds in the ICUs, in the wards, in the emergency OPDs, and make announced or unannounced observations to see which groups of professionals are strictly adhering to hand hygiene. Are the doctors doing well? Are the nurses doing well? Are the janitors doing well? Everyone, are the security individuals, lab professionals, everyone, are the porters, are they adhering to hand hygiene protocols? So as a group, they will do assessments, and then as individuals also they will do assessments. So this could be announced. So you may know while you are working in your wards that on that particular date, then hand hygiene rounds could be done, or you, without communicating with you the status or to who these individuals are, then they, instead of wearing hospital clothes or scrubs, just by regular clothes, they may do rounds. They may unnotified rounds. So the whole purpose is for you to learn from. Okay, so if you are doing things correctly, and to learn from one another, to learn best practices from one another. And this is a common occurrence. It's just new to our country, but it's a common occurrence in many developed countries. It's easy to implement. It's easy to feedback. You can even integrate it to annual performance evaluations, as I've just mentioned. The next question about N95. N95s are particularly useful for infections which are transmitted by aerosols. As I've said, small droplets which can be transmitted to nearby individuals or further away individuals, such as tuberculosis, measles, varicella, etc. So that's where really they have the most use.
Okay, so the second question is if you could please repeat hospital outbreak prevention strategies.
So there are many things that I mentioned, if I have understood correctly. So the outbreak prevention strategies, there are steps in investigating them. So the first thing is you try to identify the source of the outbreak and what is the mode of transmission. Is it being transmitted by airborne contact, by vectors, by insects, by infestations, etc.? And then you do case definitions. For example, if it's dengue, for example, dengue fever, then you confirmed case of dengue is this, probable case is this, possible case is this. So usually confirmed cases are clinical signs plus confirmatory tests. And then you try to understand the severity of the problem in order to be prepared with the equipment that you need, because if it's a severe infection that's running around, you have to have adequate prevention tools, adequate antibiotics, adequate isolation rooms, etc. And also you have to understand how fast it's spreading and how fast it's killing patients as well, so that if your human source is not enough, you start recruiting more human resource, just like what happened during the COVID outbreak. And then you develop a line listing of cases, as I've mentioned. This is just a table whereby someone just sits down, and whenever they are notified of new cases, they try to log in the basic statistics of each new diagnosis so that to identify shared exposures. You analyze past outbreaks which have happened in other hospitals or your own hospital to learn from lessons. For example, when the SARS-CoV-2 outbreak occurred, many minds were reminded of the SARS-CoV-1 outbreak 20 years ago. So what happened then? How did people control that SARS-CoV-1? What lessons can we implement here? And then finally, you implement your control measures. And all the while, as you proceed through this, you communicate, you document your findings, because it's very important for people to learn from experience as well as for the health authorities to document what's going on so that the problem does not go beyond that hospital.
Okay, the third question is how could we prevent the patients with mental illness, especially when they are on their active phase of illness, since they can't identify, which might hurt them or not at the time of hospital visiting due to the nature of the illness, and also how could we prevent infections at home as well? And if there is anyone who had such an experience, can express it. Is the next question.
Thank you. That's a very important question. And this also applies to young infants who cannot take care of their own well-being. So if there is someone of an active mental illness who cannot adhere to infection prevention advice, then I would say the most important thing would be to have a very good environmental hygiene, as well as to maintain the health of the health care workers, attendants, and family members who come into contact with that person. So one of just an example that we utilize, for example, if there is a patient with an immune compromising condition, it could be an advanced malignancy, it could be an uncontrolled HIV infection, whatever. Then one of the things that we use is, of course, we protect those people. We give antibiotics, we give them vaccines, etc. But also we make sure that everyone who comes into contact with them is vaccinated or is receiving antibiotic prophylaxis if they had been exposed to something, so that that person with a mental illness or that person who cannot take care of themselves does not acquire any infectious agent from the people that they come in close contact with. Okay, so that's a very important point for such individuals. I'll be happy if there's anyone who likes to share their experience to that regard.
The fourth one is in antibiograms, how much often do physicians prescribe the red, yellow, green coded ones? And is there any local guideline to go from one code to another?
So antibiograms are not a static thing. Okay, for example, from my experience, we used to update those antibiograms every 3 months, because sometimes you have a bad outbreak and then your antibiograms all show you only red colors. You can't utilize cephalosporins, you can't utilize gentamicin, you can't utilize carbapenems or whatever. And there are certain times of the year whereby those outbreaks subside, or your hand hygiene improves, or you institute better control measures, and then it may be yellow or green. So so it's a dynamic thing. Okay, so we had implemented a local guide, a local antibiogram, but which is no longer present at Black Lion Hospital. But now we are doing the same thing at St. Paul's Hospital using a mobile application. So I mean, it's not a a novel concept. It's like anyone can do it. You just what you do is you go to your microbiology lab, you tally the results, you identify the sensitivity rates of the bacteria to each group of antibiotics. Then you design your table, you color code it, you share it among your colleagues, and you educate among them yourselves, and then that becomes a trend. So someone working in St. Peter Hospital does not have to use a guideline which is implemented at Black Lion Hospital. They might have a different scenario. So that's how things are done. In antibiograms, how much often do physicians prescribe the red, yellow, and green coded ones? Well, there are many studies which show that our antibiotic prescriptions are very harsh. In a study we did in 2016, again at Black Lion Hospital, we noticed that the patients which were being admitted to the pediatric and medical wards, to the 7th and 8th floor. Of course, this is affected by the fact that Black Lion Hospital is a referral hospital. So usually Black Lion is a second or third stop in their care. So 94% of patients presenting for admission and admitted for inpatient treatment had already received antibiotics in the preceding 14 days, and 60% of them had received more than 3 antibiotics in the preceding 14 days. So that's how often doctors prescribe antibiotics before patients are finally declared unfit and they are referred to tertiary hospitals. So there are many studies which show such findings.
Okay, thank you, Doc. Is there a need to prolong duration of antibiotics if you are using renal adjusted dose?
So using renal adjusted doses or using hepatic doses or any other adjustments is to make your antimicrobial treatment compatible with the patient's comorbidity. But it doesn't mean that that affects the duration of antibiotic treatment. For example, community-acquired pneumonia, it's 5 days. Nowadays, even there are many studies showing even less number of days of antibiotics are effective. So the individual dosing, it just corresponds to what comorbidities they have, but the duration of antibiotics is the same across the board. The adjustment is more concerns metabolism and elimination of the antibiotics.
How do we assess the quality? How do we assess the quality of cultures and drug sensitivity taste services in most of our setups?
So now the technology of microbiology tests is very dynamic. So previously we used to rely on manual testing. Now we rely on automated testing. So there are many technologies such as liquid culture systems, Bactalert, Vitek, and then the latest technology, which is MALDI-TOF, which is dependent on mass spectroscopy. So this take out the human element of the microbiology process and lead to better sensitivity of the results. So already there are some institutions in Ethiopia which implement these liquid culture systems, and I am sure ROHA are also thinking about these automated microbiology culture systems, which are fast, which are very high yield, and provide reliable, very reliable and sensitive tests. Yeah. And I see another question on water being a main problem in many hospitals,
Yes.
and how effective are sanitizers that we are using. Yeah. So as any pharmaceutical product, as any medical medicine, and as any lab reagent, of course, quality of sanitizers should be monitored by the regulatory authorities. So one thing that you should know is sanitizers or alcohol rubs, alcohol gels are only effective in preventing microorganisms which do not have spores. Okay, so for example, if you have Clostridium difficile, for example, running around your hospital, it will not be destroyed by alcohol rubs. You have to go and wash your hands. You have to use water and soaps to completely eradicate it. So alcohol rubs are not a magic solution. They will not prevent everything. So the main thing, as has been mentioned, is to make sure the water supply of a hospital is clean enough, is well functional. Simple things like soaps are well stocked. The sinks in examination rooms, in wards are functioning well. The toilets are functioning well. These are very simple things, but with far-reaching consequences.
Thank you, Dr. Tinsae, for your very informative and brief answers for our questions and your presentation. So far, these were the questions that were forwarded. Thank you.
So thank you very much, Dr. Malik. Thank you very much, Dr. Tinsae, for addressing each questions accordingly and in detail. And to all the participants that have engaged in the Q&A session, thank you very much. Your questions are more than welcome and are also a learning opportunity for others as well. So as I've stated earlier, the post-CME quiz link was shared and the time is up, so we're no longer accepting the responses. So with that said, we can directly proceed to attempting the post-CME quiz. So I will shortly share it and we can attempt it together with Dr. Tinsae. So the first question reads, which single intervention is the most important for infection prevention in hospitals? So A is hand hygiene, B is avoiding overcrowding, C is strict outbreak investigation, D is isolation rooms.
Yes, as I've tried to highlight, hand hygiene is the most important area of infection prevention.
So thank you. So the answer for the first question is A. So the second question reads, which of the following diagnosis is transmitted by aerosol, droplet, and contact routes? So the first choice is hepatitis A, B is measles, C is impetigo, and D is pertussis.
Again, should I share?
Yes, please do.
Yes. So the first option is contact transmitted. The measles is transmitted by all three routes. Impetigo, it's contact transmitted, and pertussis is by droplet. So the answer is measles, B.
Thank you. The third question reads, which is not a vaccine preventable disease? A is meningococcemia, B is varicella, C HIV, and D hepatitis B.
Yes, here it's pretty clear that the A, B, and D are vaccine preventable, but C is not.
Thank you. The last question reads, which action does antimicrobial stewardship include? A, confirming a diagnosis of an infection, B, ensuring a correct antimicrobial treatment, C, preventing unwarranted prolonged number of antibiotic days, and D, all of the above.
Yeah, so all of these are components of antimicrobial stewardship. So all three are correct. So D, all of the above.
So thank you very much. So with that, we will conclude our quiz. So thank you very much, Dr. Tinsae, for presenting us a very important topic in an informative and engaging way. I would also like to thank the Ethiopian Society of Internal Medicine and the ROHA Medical Campus for collaborating with us in the making of this webinar. And thank you to all our attendees that have attended the webinar. So we'll see you in the next one. Thank you.
Thank you very much.